Okay, sorry for that interruption. Um, this has to be one of the hardest topics that I've ever covered. Now, I think I would have spent at least 2 weeks on this, and things were actually quite difficult to piece together, but I think I've pieced it together. And if anyone has any arguments against this, please let me know. Okay, my disclosures, nothing apart from images provided by Tracy Technology. Now, when we think of the eye, we tend to think of it as a schematic eye, but it actually isn't. There's nothing rotationally symmetric or coaxial about the eye. Now, a single ray of light from the fixation point of the fovea doesn't pass through without some form of deviation inside here. Now, each optical component has its own axis. And most corneas and most likely lenses also are longer in the horizontal plane as compared with the iris lenticular space. Compared with the horizontal plane. Compared with the vertical plane. So how do we find a center in the eye? Again, we need to go back to basic optics, which as used in the literature is actually very, very confusing. To be clinically relevant, I mean, most terms and concepts, they need to be disregarded. What the hell is this? And only the core ones, which we can identify, need to be retained. Now, there's all sorts of axes which have been described in the eye. Now, most of these you actually can't identify. Now, a lot of angles as well, and too many other terms. Now, when you look at the literature, you find, that these things are used interchangeably, they're used wrongly, and a lot of the literature actually is very, very difficult to understand because the right terms have not been used. Now, as I said before, most of these are relevant only for a schematic eye. And for clinical purposes, only two of these can be identified. What can we identify? We can identify the center of the pupil and the corneal light reflex. What is the corneal light reflex? We know what the center of the pupil is. The corneal light reflex, it's really the reflection from the front surface of the cornea. This is virtual and upright, but where is it actually located? It's located on the iris plane. Now, you can't really say there's a center unless all the Purkinje images align and are located at the center of the pupil. Now, how common is that? Not that common. Now, the ideal centration option for refractive surgery has been debated at least until 1990. And yet, there's no agreement between whether it's the center of the pupil, the corneal light reflex, or somewhere in between. Now, so again, where would be the ideal center? For this, we need to make two assumptions and a statement of fact. The human eye will naturally, the assumptions are, the human eye will naturally gravitate towards a position where its function and comfort are maximized. And the ideal center should be at the intersection of the visual axis with the cornea. I mean, that makes sense. Now, the statement of fact is a light ray normal to a refracting surface will pass undeviated through a refracting medium and maximal reflection will occur at that point. So that should really be where the visual axis is intersecting with the cornea. Now, unless someone else has any opposition to this, I will assume that that's a visual axis. Now, why are we still using the visual axis? It comes from this paper from 1993, where they came to the conclusion that the visual axis was located between the center of the pupil and the corneal light reflex, but closer to the corneal light reflex. Now, as far as I know, this has not been replicated, and the methodology used is not very convincing to me, at least. So the 2 points which can be visually located are the pupil center and the corneal light reflex. Now, if they are not co-located, and they are not in most people, what the distance between those two is called the angle kappa. Now, to identify this, you have to have a Placido disc system. So, assuming that the patient is looking at the center, the very center of the Placido disc is where you find the corneal light reflex. Now, why do I have CSCLR? Because that corneal light reflex has to be sighted by the surgeon. Now, if you sight it from the side, then the corneal reflex will tend to move a little bit. Now, as far as I can see, as I can make out, this must be the location of the intersect of the visual axis with the cornea. What are the definitions? AAO defines the angle kappa as the angle between the pupillary and the visual axis. You can't locate the visual axis, so you add up the two assumptions and the one factual statement, and what we get is a corneal light reflex. Okay, in practice, angle kappa is the angle between the pupillary axis and the corneal light reflex when observed and illuminated coaxially. Now, this has actually been looked at on a population-based survey. This is from Iran. And the mean angle kappa is about 5.5 degrees nasal to the pupillary center. There can be some vertical displacement as well, no gender difference, and interestingly, it tends to decrease with age. It's highest in emmetropes, lowest in myopes, and sort of in between in hyperopes. Now, what about the pupil center? We all know this. Pupil center will tend to shift with pupillary dilation. Now, this is an undilated pupil. This is a scotopic image. You can see that in the undilated, that is not exactly at the center. So the pupillary center will shift as well. So that is one of the reasons why I stopped doing wavefront guided treatments. Because by convention, they all have to center on the pupillary axis. So here are the strategies that we have. We can either center on the pupil, which most refractive platforms seem to do. You can center on the corneal light reflex or center somewhere in between. My personal experience, I've been using for the past 10, I think almost 12 years, platform which has a topography-guided LASIK, which enables me to center on the corneal light reflex. The results have been so good that I really haven't made any changes in 12 years. How do you center on the corneal light reflex? I mean, this is the real patient here. You can see that this is not centered. Now, when that red light is moved here, basically what is happening here is that your fovea is looking at the patient's fovea. So that should be a direct line from the patient's fovea to your fovea. So that should be the center. What about in cataract surgery? Well, again, it's very important for multifocal and aspheric lenses. But IOL's auto center, so what do we do? Well, we have some way of telling by using a multi-purpose machine called the iTrace. Now, the only problem I have with the iTrace is that they introduce another term, angle alpha. So it's a multi-purpose device that can do all these things. And here you see, this is a patient before surgery. The green is the center of the pupil. The red is the corneal light reflex. And the blue is what they call the alpha point. That should be the center of the capsular bag. That is the assumption that's been made. That's the center of the capsular bag. Now, all these things are very closely clustered together. So this patient should be a very good patient for multifocal. As we can see, I mean, there seems to be a little bit of tilt here, but apart from that, everything is clustered right in the center. And as expected, this patient is extremely happy. He drives, he does every single thing. He hasn't had a single halo problem. And he's not the only one. I mean, there's a number of them. So, for cataract surgery, centration, you need to understand corneal topography and wavefront aberrometry. Now, this is an eye where everything is coincident, right from the cornea to the retina. So we can see the retinal spot diagram is actually very well clustered and the point spread function is excellent. Now, here the cornea seems to be fine, but there's cataract and the point spread function, goes down. Here again is an eye with extremely good alignment. Everything is clustered right in the center. Now, this patient should be a very good candidate for a multifocal or an aspheric IOL. Here, you have a big distance between the corneal light reflex and the presumed center of the bag. So this would be a case where you would be a little bit hesitant in using a multifocal implant. This is a mid-level, it's borderline, the distance is there. What happens when you put the lens? I mean, you'll only know once you put the lens in. You can also use it to check the lens for centration and tilt. And there's all sorts of other things that you can do with it, with toric IOL placement, lens centration. I really haven't explored a lot of this. Now, this is a real patient. This is a real patient. You can see he has astigmatism. Now, this is him with the center on the pupil. Look at that. You've got quite a bit of coma if you center on the pupil. Now, this is centered on the corneal light reflex. Almost all the coma is gone, and what he is left with is astigmatism. Now, what happens when he puts his glasses on? He's actually very happy with his glasses. When he puts his glasses on, he is looking through the corneal light reflex. You can see that he's not looking from the pupil center. He's looking through the corneal light reflex. This is where his eye naturally wants to go. So what happens to the point spread function? There, clusters. So I think, at least for me, this is very convincing. If anyone has any doubts, please express them.